So vasovagal syncope is overdiagnosed, and this is bad. Why does this happen? This is a real case. An 80-year-old woman with recurrent syncope goes in and out of a small ED over some months, and what's the diagnosis she keeps getting? Of course, vasovagal syncope. And then, on one visit, whoops, it's intermittent complete heart block. So a kind cardiologist gives her a pacemaker, and her syncopes stop happening. Getting a diagnosis wrong is one thing, but why did multiple junior doctors give her the same wrong diagnosis? You've got your three big boxes for syncope: cardiac, reflex or neurally mediated, orthostatic. Now the diagnosis of cardiac syncope relies on objective markers: demonstrated arrhythmia, abnormal ECG, a big old murmur. Orthostatic syncope is based on relatively objective facts too. The syncope was associated with postural change, or there are reproducible orthostatic symptoms in the department. And under reflex, situational and carotid sinus sensitivity usually have some solid component of the history or exam to lean on too. So what's left over? Vasovagal syncope. And then enter the uncertainty that we always have in the ED. And guess where it gets disproportionately dumped? That's right, on vasovagal syncope. But that's not all. A second case. Alarm goes off in the ED and we find a guy collapsed in the bathroom. Guy's Māori, but looks green for how vasoconstricted he is. Blood all over the floor and walls like a Tarantino movie, clearly coming from a lower GI bleed. Get him into resus, blood pressure might have been 80/50. One of the specialty doctors comes in, notices the heart rate of 55 and says, it's a vasovagal. The patient is still green with vasoconstriction, teetering on hemorrhagic shock, and he still gets a diagnosis of vasovagal syncope. Yes, he has an appropriate vagal tone. But no, that doesn't make it primarily a vasovagal. Despite the neat construct of reflex, orthostatic, cardiac, there is absolutely a spectrum, especially between reflex and orthostatic syncope. This is the second issue. Anyone with a hint of inappropriate vasodilation or vagal tone is at risk of getting this diagnosis. Now the last reason that vasovagal syncope is an overly popular diagnosis is the data. What data? The data from tilt table studies. Now in any normal diagnostic study you compare the test, e.g. D-dimer, to a gold standard, aiming to represent the true disease status. For D-dimer this might be CTPA. Sensitivity is true positives over total positives, specificity is true negatives over total negatives. Now there's no gold standard for vasovagal, so what do they do instead? They look at the tilt table results among those with symptoms. Not a gold standard, no. Now if you compare a test to a gold standard, you learn something about the test. But if you look at the test in a group with symptoms, you just get a positivity rate with no external reference point. So the so-called sensitivity, as they call it, is not sensitivity at all as we know it. And then to calculate specificity, they get a group with no symptoms, tilt table them and calculate specificity that way. But how good was the matching? For this to be valid, they'd have to match for anything that could affect tilt table results. Age, sex, medications, medical history at minimum. And guess how many studies have done this? None. They match for age and occasionally sex if you're lucky, but not for medications and not for medical history. So really, these are two separate studies. One, positivity rate of tilt tables amongst syncope patients, and two, positivity rate among a much healthier group that happens to be matched for age. These are not diagnostic accuracy studies as we know them. And this data informs textbooks and references that in turn informs well-meaning clinicians. This is how vasovagal ends up occupying a disproportionate amount of room in the headspace of clinicians. Now what's the real problem of overdiagnosing vasovagal syncope, apart from just being wrong? Here's one last case. 1993 NBA playoffs. Reggie Lewis collapses. He goes to hospital, gets a tilt table which is positive. Diagnosis? Neurally mediated syncope. A few months later, dead from VF and hypertrophic cardiomyopathy. Surely this is an isolated case, right? Not so. Of patients who are eventually diagnosed with arrhythmogenic syncope via a loop recorder, guess how many have positive tilt tables? 45%. So when we hear anything about vasovagal syncope based on tilt table studies, should we believe it? So look, it's totally fine to diagnose vasovagal, especially if they're young, they've had a nice long prodrome, maybe they felt hot, or it was after prolonged standing and they're not otherwise at risk. But beware, if they're old, just remember what happens to vagal tone with age, it goes down. Or if the story isn't classic for vasovagal syncope, you might not necessarily need to admit them to hospital, and it may still be possible to call them low risk. Just please don't try to replace your diagnostic uncertainty with the label vasovagal.